Dissociative Identity Disorder, DID, formerly known as multiple personality disorder, represents one of the most complex and misunderstood mental health conditions in modern psychology. At its core, DID is characterized by the presence of two or more distinct personality states or experiential identities that recurrently take control of a person's behavior, accompanied by gaps in memory and awareness. These separate identities, often called alters, develop as a sophisticated psychological defense mechanism in response to overwhelming trauma, typically experienced during critical developmental periods in childhood. Rather than being merely a curiosity or dramatic psychological phenomenon, DID is fundamentally a creative survival strategy that allows the psyche to compartmentalize unbearable experiences and emotions. The development of DID is intrinsically linked to severe childhood trauma, particularly repeated instances of physical, sexual, or emotional abuse occurring before the age of 9. During these formative years, when a cohesive sense of self is still developing, the child's mind creates dissociative barriers as a protective measure. Each alter may hold different memories, manage specific emotions, or fulfill particular functions within the person's life. Some alters may be aware of others, while some may exist in complete isolation, creating internal communication systems that range from cooperative to conflictual. These alters can differ dramatically in age, gender, preferences, mannerisms, speech patterns, and even physiological responses like allergies or visual acuity. Contrary to popular media portrayals, transitions between alters, known as switching, are rarely dramatic or theatrical. More commonly, they manifest as subtle shifts in posture, vocal tone, facial expressions, or behavioral patterns that might be imperceptible to casual observers. People with DID often experience these transitions as confusing gaps in time or awareness, finding themselves in unfamiliar situations without memory of how they arrived there, discovering items they don't remember purchasing, or being addressed by names they don't recognize. This experience of lost time and discontinuity in personal narrative represents one of the most distressing aspects of living with DID. The path to diagnosis is typically long and complicated, with individuals often receiving multiple misdiagnoses before DID is correctly identified. On average, people with DID spend 7 years in the mental health system before receiving an accurate diagnosis. This delay occurs partly because DID exists on a spectrum of dissociative disorders and shares symptoms with conditions like PTSD, borderline personality disorder, bipolar disorder, schizophrenia, and various anxiety disorders. Additionally, many individuals with DID develop sophisticated coping mechanisms that mask their symptoms in clinical settings, and some alters may deliberately hide the condition from treatment providers out of fear or protective instincts. The treatment approach for DID is multifaceted and requires considerable expertise in trauma-informed care. The therapeutic journey typically unfolds in phases, beginning with safety establishment and symptom stabilization, followed by trauma processing, and culminating in integration or internal cooperation. Integration, the gradual fusion of alter personalities into a cohesive whole, was once considered the definitive goal of treatment. However, contemporary approaches recognize that functional multiplicity, where alters collaborate harmoniously without necessarily merging, can also represent a successful treatment outcome. This paradigm shift acknowledges the protective function that dissociation served and respects the autonomy of the person's internal system. Beyond psychotherapy, holistic management of DID often includes supportive measures like medication for comorbid conditions, grounding techniques for managing dissociative episodes, expressive therapies for processing traumatic material nonverbally, and somatic approaches that address trauma stored in the body. Social support networks, both professional and personal, play a crucial role in recovery, helping individuals build consistency in their external environment while they work toward internal coherence. Support groups specifically for dissociative disorders can provide validation and practical strategies from others with lived experience of similar challenges. Despite significant advances in understanding and treating DID, stigma and misconceptions persist, both within society and the healthcare system. Media portrayals often sensationalize or villainize people with DID, perpetuating harmful stereotypes that equate multiplicity with dangerous behavior. In reality, individuals with DID are far more likely to be victims rather than perpetrators of violence, having survived profound childhood trauma. This stigma can discourage people from seeking help and complicate their journey toward healing. Education and awareness efforts are essential to dispelling these misconceptions and creating more supportive environments for those living with DID. Looking toward the future, research into the neurobiology of dissociation is yielding fascinating insights into how trauma physically alters brain development and function. Neuroimaging studies have revealed distinct patterns of brain activity during dissociative states, and genetic research is exploring potential biological vulnerabilities that may interact with environmental trauma. These scientific advances are gradually shifting the perception of DID from a purely psychological phenomenon to a complex biopsychosocial condition with measurable neurobiological correlates. This evolving understanding holds promise for more targeted and effective interventions, potentially including approaches that combine traditional psychotherapy with emerging somatic and neurobiological treatments. In conclusion, dissociative identity disorder represents not just a psychiatric diagnosis, but a testament to the mind's extraordinary capacity for adaptation in the face of overwhelming circumstances. By understanding DID as a creative survival response rather than a deficit or dysfunction, we honor the resilience of trauma survivors and create space for more compassionate and effective approaches to treatment. Through continued research, education, and advocacy, we can work toward a future where those living with DID receive the understanding, support, and specialized care they deserve on their journey toward healing and integration.